Science! Science! Let's talk today about the largest and most complex organ in the human body. The brain. It's composed of several parts that control what you think, how you feel, where you move, what you see, hear, and taste, and many other functions. The cerebrum, the cerebellum, the diencephalon are some of the major sections of the brain. The brain is the best protected organ in the body. It has multiple layers of protection, starting with the first layer of protection being the skull, or cranium. This acts as an armor shielding the brain from blows. The next layer of protection is the meninges, which has three membranes that surround the brain and spinal cord. It keeps it from being damaged by contact with the inside of the skull. And the final layer of protection is the cerebral spinal fluid that the brain and spinal cord basically float around in. If it's so well protected, then why do we see people with brain damage? Traumatic brain injury, or TBI, refers to damage of the brain caused by an external physical force, such as a car accident or a gunshot wound to the head or falling off a house. A traumatic brain injury is not caused by something internal, such as a stroke or tumor, and it doesn't include damage to the brain due to prolonged lack of oxygen. It's possible to have a TBI and never lose consciousness. For example, someone with a penetrating gunshot wound to the head may not lose consciousness. The brain is about 3 to 4 pounds of extremely delicate soft tissue floating in fluid within the skull. Under the skull, there are 3 layers of membrane that cover and protect the brain. The brain tissue is soft and therefore can be compressed or pulled or stretched. And when it's sudden speeding up or slowing down, such as in a car crash or in a fall, the brain can move around violently inside the skull, resulting in TBI. So let's talk about the closed versus open head injury. Closed means the skull and brain contents have not been penetrated or broken through, whereas open means the skull and other protective layers are penetrated and exposed to air. So a classic example of open head injury is a gunshot wound to the head. In a closed head injury, damage occurs because of a blow to a person's head or having the head stop suddenly after moving at high speeds. This causes the brain to move back and forth or from side to side, such that it collides with the bony skull around it. And this jarring movement bruises brain tissue, damages axons, part of the nerve cell, and tears blood vessels. After a closed head injury, damage can occur in specific brain areas. We call that localized injury, or throughout the brain, a diffuse axonal injury. Damage following open head injuries tend to be localized, and therefore damage tends to be limited to a specific area of the brain. However, such injuries can be as severe as closed head injuries, depending on the destructive path of the bullet or other invasive objects within the brain. Primary versus secondary injuries. Primary injuries occur at the time of injury, and there's nothing that physicians can do to reverse those injuries. Instead, the goal of the treatment team in the hospital is to prevent any further or secondary injury to the brain. So here are some primary injuries. Secondary injuries occur after the initial injury, and usually within a few days. Secondary injury may be caused by oxygen not reaching the brain, which can be the result of continued low blood pressure or increased intracranial pressure from brain tissue swelling. Skull fracture occurs when there is a breaking or denting of the skull. Pieces of bone pressing on the brain cause injury, often referred to as a depressed skull fracture. Localized injury means that a particular area of the brain is injured. Injuries can involve bruising, contusions, or bleeding, hemorrhages, on the surface of or within any layer of the brain. Diffuse axonal injury, DAI, involves damage throughout the brain and loss of consciousness. DAI is a stretching injury to the neurons, the cell bodies of the brain, and axons, fibers that allow for communication from one neuron to another neuron. I wish Carl could communicate better, that neuron. Carl! Everything in our brains do for us depends on neurons communicating with each other. And when the brain is injured, axons can be pulled, stretched, or torn. And if there's too much injury to the axon, the neuron will not survive. In a DAI, this happens to neurons all over the brain. This type of damage is often difficult to detect with brain scans. The brain is like any other body tissue when it gets injured. It fills with fluid and swells. Because of the hard skull around it, however, the brain has nowhere to expand as it swells. This swelling increases pressure inside the head, intracranial pressure, which can cause further injury to the brain. Decreasing and controlling intracranial pressure is a major focus of medical treatment early after TBI, and if intracranial pressure remains high, it can prevent blood passage to tissue, which results in further brain injury. Trauma, the leading cause of death in drug deals. The leading cause of death in people under 40 years of age. Every year, over 117,000 people die from trauma in the United States, and many of these deaths occur in the pre-hospital environment. No matter the level of care that an individual can give to a trauma patient, the end result weighs on two common denominators, and that is time and recognizing the level of care required for these patients. Although we will only be on an ACP level when we are done this course, knowing the critical care treatments may help us better prepare that patient and improve their outcome. We will have a better understanding when treatment they will require and anticipate what sort of care they will need. When it comes to traumatic patients, my first thoughts are usually a bloody scene or a head injury. Patients that are bleeding are typically something as PCPs and ACPs we can deal with, unless it's internal. But what do we do with head injuries? Unfortunately, there's not much that we can do for primary injuries except for education. In pre-hospital care, our main priority is to slow down and completely stop secondary brain injuries from occurring. And for the most part, especially as a PCP, the best we can do is try and maintain the airway and do a little hyperventilation when indicated. For myself, I usually turn to the student and I say, "This one's yours." There really isn't much that can be done unless there is access to an OR. But there are a few different things that can help the patient's outcome if recognized and treated early enough. One of the most important numbers that they focus on in a CCP setting is the mean arterial pressure. The mean arterial pressure is the average pressure in the arteries during one cardiac cycle. A true mean arterial pressure can only be measured through an invasive procedure, systemic vascular resistance times cardiac output. But there is a calculation that can be done in the field to get an estimate. SBP plus 2 times DPP divided by 3. Say that 3 times fast. In pre-hospital care, we tend to focus on blood pressure as a measurement of perfusion in the body. MAP is way more accurate with measuring the amount of perfusion the organs are receiving. We also need to focus more on MAP because it is the pressure that has the greatest effect on blood flow autoregulation within the organs, and on hemodynamic homeostasis mechanisms, such as baroreceptors. There is some controversy over what the golden number of MAP is, but most seem to agree that you want it no lower than 65 millimeters of mercury. They just have no scientific evidence on why that is, which is why it's so controversial. For brain injuries, every time MAP drops below 85 millimeters of mercury, it doubles that chance of morbidity and mortality in the patient. We also want to keep a close eye on ICP. No, not Insane Clown Posse, you juggalos. In the field, our greatest tool to measure ICP is through clinical findings such as posturing, respiratory patterns, etc., etc., etc. In the hospital, they take a much more invasive approach through the cannulus in the ventricles and subarachnoid screws. With these invasive procedures, the risk furthers damaging the brain though. And recently they have started using a non-invasive device called the TD-TD. It essentially measures ICP the same way we measure blood pressure, except they do it around the eye. It is completely non-invasive and limited constrictions. The optimal goal for ICP is less than 20 millimeters of mercury. Let's all that say it out loud. Come on, I can hear you guys. The optimal goal for ICP is less than 20 millimeters of mercury. Good participation, except for you in the back row. Corey. Which brings us to cerebral perfusion pressure. CPP equals MAP minus ICP. CPP is important because it measures cerebral blood flow, which represents how much oxygen and metabolite-rich blood is reaching the brain. They like to keep CPP around 70 to 80 millimeters of mercury, and with every drop of 10 millimeters of mercury, the mortality rate of the patient increases. And even though we cannot measure each of these things in the field, each value plays an important role in the big picture. Fluid resuscitation. Important to these patients and is relatively safe, as crystalloid solutions do not aggravate cerebral edema. If crystalloid solutions are not bringing up MAP, a vasopressor like norepinephrine can be administered to achieve a MAP greater than 85 millimeters of mercury. When taking the airway of these patients, fentanyl is the drug of choice to help blunt sympathetic responses, as well as ketamine for sedation. For paralytics, Sux is not necessarily the drug of choice in head injuries, but is not absolutely contraindicated. Once the patient is tubed, if they aren't bucking the tube, long-term paralytics should be avoided as they will impair further assessments of the patient. Pharmacologically speaking, there are a couple of different medications that can be administered to improve patient outcome when herniation is suspected in a TBI. Hypertonic saline, 3% saline, is the electrolyte that helps promote shrinkage of the brain. Because of its high osmolality, it extracts fluid from the swollen cerebral tissue, allowing for the brain shrink. One of the main disadvantages to the saline is that it can be very hard on the kidneys. Although this is not a permanent solution, it does give the patient more time while getting them to a trauma center. Another drug, similar to 3% saline, is Mannitol. Mannitol works by increasing plasma osmotic pressure, which dehydrates the brain and decreases intracranial pressure. But of course you already knew that, I'm sure. As of lately, Mannitol has become more controversial. More studies are showing that if Mannitol is used over a long period of time, it could cross the blood-brain barrier and cause increased swelling. It is also getting less common to use Mannitol, as it is sensitive to low temperatures and starts to crystallize at 10 degrees Celsius, which means we can't use that for 8 months out of the year in Saskatchewan. It's so cold here. Depending on the doctor in charge, both Mannitol and hypertonic saline have run simultaneously. Another drug that may be seen in critical care setting is glucose. Glucose is the main form of energy for the brain and is required for it to function. It helps the brains with the most basic functions as well as its higher order functions such as decision-making, calculations, and focusing. Brain cells need 2 times the amount of energy as any other cells in the body. It is really important to keep these patients' sugars sustained, but also be cautious of not giving them excess sugars. Glucose will help keep the unaffected brain tissues healthy, but if given too much, can cause even more cerebral edema. Glucose causes water shift from the intercellular fluid, ICF, to the extracellular fluid, ECF, space and contraction of cell volume. You can see how this could be detrimental to someone with a brain injury. Another medication to consider is anti-seizure medications. If the patient had a seizure prior to arrival due to the injury, a sedative may be given prophylactically. Some centers may give sedatives prophylactically whether the patient has seized or not, just to avoid any further disruptions of the brain. Not all treatments for the brain injuries are pharmacological. One of the most common non-pharmacological treatments has to do with the airway. Hyperventilation is one of the most rapid, non-invasive ways to decrease ICP. Cerebral blood flow relies heavily on PaCO2. So when we hyperventilate, it causes a rapid decrease in PaCO2, which leads to arterial vasoconstriction, which subsequently decreases cerebral blood flow. Other things we can do to slow secondary brain injury are to slightly elevate the patient if it's possible, as well as avoid putting on a neck collar if you can immobilize the neck in another way. Elevating the patient improves venous blood return from the brain, and avoiding a collar also encourages increased venous return. When we put the collar on, we are increasing the risk of slowing venous blood return. Overall, there's not a whole lot more that can be done in the critical care setting when it comes to a traumatic brain injury, and definitive care in these situations is a neurosurgeon. But it's super important that whatever level of care comes across these patients first recognizes the severity of the injuries and acts quickly to alert the proper channels and perform the treatments within their scope. Regardless of what level of care we are, the two most important things to remember is not to allow these patients to become hypoxic or hypotensive. Trauma, the leading cause of traumatic injuries. When it comes to trauma, hemodynamically unstable patients aren't uncommon. I've seen them all the time. Sometimes the source of bleeding is very obvious, and sometimes we have no better choice but to guess that something is going on internally. The decision in the field by CCTPs to administer blood products comes from a detailed assessment, vitals, and laboratory findings in some areas. Portable ultrasound. Ultrasound doesn't necessarily change the treatment when it comes to a trauma patient, but it allows for expedited transport to the proper tertiary centers as well as less messing around at the hospital, and gets patients in the OR quickly if the CCTP can identify the problem. If they have access to it, they may carry an iStat, which allows them to decide which blood product is most appropriate in the situation. iStat is capable of so much more than determining what blood product to administer. It's basically a portable laboratory that helps with differentials in the field. As with any medication, the decision to give blood is taken quite seriously, as there can be many complications that come along with it, and it's not as simple as just hanging a bag and letting it go. There's also a lot to take into consideration, as blood comes in many forms. Whole blood products are rarely given. They contain all the components of blood, including red blood cells, white blood cells, platelets, plasma, and electrolytes. Whole blood products are only to be considered if there is greater than 25% blood lost. And it shouldn't be your initial treatment whenever possible. Crystalloids and colloid solutions must be attempted first. The risks and costs must always be taken into consideration. It is very easy to cause volume overload in patients with cardiac compromise when administering whole red blood. Packed red blood cells, what most CCPTs would use, contain all of the same components as whole red blood, except 250 mils of plasma is extracted from each unit. Packed red blood cells also have approximately 70% of leukocytes removed from each unit, which is beneficial as it decreases the risk of febrile non-hemolytic reactions. Platelets are a little more rare in the field, but could be seen in intrafacility transfers. They are indicated in patients who are bleeding from thrombocytopenia. They may also be considered with DIC or patients receiving chemotherapy. Other blood derivatives that may be seen in the field are vitamin K and prothrombin complex concentrate, PCC. These are indicated in patients with major blood loss who have a vitamin K deficiency or an INR greater than 1.5. INR is obtained through laboratory tests and measures the viscosity of blood, and is usually paired with a PTT test, which sometimes how long takes the blood to clot. Another drug that CCPTs may administer, and some ACPs across Canada, is tranexamic acid. TXA is an antifibrillinic agent that can reduce blood loss and is often given in fields for traumatic hemorrhage shock and could decrease the need to transfuse blood. The basic rule of thumb is that if a patient is thought to require blood transfusion while preparing for that, while obtaining appropriate orders, TXA is given. Healthcare is very complex and forever changing in the industry, and especially in pre-hospital care. And now more than ever, we are seeing many different changes in the field, allowing for us to do more invasive procedures, administer a variety of medications, and overall improve patient outcomes. But regardless of how far ahead we get in technology and field treatment, something I have learned and am always being reminded of is that without proper BLS treatment, regardless of your level of care, you won't have a good foundation. When it comes to brain injuries, there's most definitely improved patient outcomes when it comes to administering drugs such as Mannitol or hypertonic saline, but if focus is lost on stabilizing the ABCs and ensuring the patient doesn't become hypoxic or hypotensive, the drugs aren't going to do squat. MAP is a very common and fairly easily obtained vital that can be more predictive of patient outcome. It gives you a goal in traumatic brain injuries to help maintain perfusion in the brain, and it's more predictive of tissue perfusion. Making sure that your patient does not have a hypoxic or hypotensive event can be more life-saving than a lot of advanced treatments out there. And that is science.
I push all the right buttons, lay out for me.